All right. Thank you so much, Dr. Vicari. Um, I think in the interest of time and everyone's busyness, we can go ahead and move forward to the next session. But if anybody has a question they'd like to ask Dr. Vicari, you're more than welcome to type it into the chat, and Dr. Vicari can try to answer it during this next session, or we can get those questions answered at some point later on. So, so moving on to our next session this morning, the second of two lectures will be by Dr. Celia Alpuche Aranda, who is the director of the Research Center for Infectious Diseases at the National Institute of Public Health in Mexico. And she'll be giving us a little bit more of a detailed example from Mexico and how the country has tried to understand the disease burden of influenza and perhaps a little bit of COVID as well, and also how to engage with decision makers. And so she'll be going ahead now, and this session will go until about 9:15, after which we'll have our closed meeting. And again, feel free to put in questions in the comment section. Thanks. Celia, are you ready to go? Or you might be muted.
Sorry.
Okay.
I was trying and I couldn't. Thank you for the invitation, and it's great to be here. And I hope I can give some data about burden of disease in Mexico, but it's very limited, the information. So it's going to be a combination of surveillance plus burden of disease, because we actually need good surveillance data to do analysis for burden of disease. So that's going to be combined. And the title that I added is Influenza Past and Present, because it's impossible for us not to mention the experience that we had with 2009 pandemic, and the data that we have with burden of disease is also very important. Lessons learned that we have used it to respond to the COVID-19 right now. So, sorry. There's nothing to declare. And the agenda that I want to address here, there are these 4 points. It's influenza in Mexico before and at the time of the 2009 H1N1 pandemic, current influenza surveillance system in Mexico. And this is going to be combined at the same time with burden of disease of data that we have from Mexico, and finally some reflection and conclusions. So to start with influenza before and at the time of the 2009 H1N1 pandemic, I really need to mention some antecedents. So Mexico started to have in 1994 in the health law, we included influenza as an obligatory notification disease. However, it was very limited, the information that we were getting with influenza. And the laboratory network for influenza was basically in Mexico City. It was absolutely centralized. And the most of the information that we were getting, it was from the central part of Mexico. Mexico City, state of Mexico, Tlaxcala, and surrounding states. So it was very limited. And in fact, we didn't have an official epidemiological surveillance system for influenza till now. So it was since 2003 when we began in the preparedness and response plan for influenza pandemic that we actually developed an influenza surveillance system that was put in place in 2006. It was the new surveillance system called CISPE-Flu, and it was trying to resemble the FluView system, the analysis that you have in the United States, and it was based on ILI. Mostly, it was primary care units. I mean, we didn't have hospitalization data, and they started with around 300 units, clinical unit that it was called influenza monitoring clinical units around the country, USMIS, and it was distributed in different states in Mexico. Also, at the same time, in 2016, there was the development in strategic reserve of protection supplies, and it was also Tamivir, and there were pre-contracts for vaccine development in case of pandemic and so on. So there were agreements with the pharmaceutical industries and the Ministry of Health. And finally, we got the multi-sectorial operational strategy of the National Preparedness Plan response to influenza pandemic. So at this point, Mexico was aligned with the WHO recommendations for the preparedness and response plan for influenza pandemic. The official structure available was used. So we have the National Committee for Health Safety Council, and we have also, it was mentioned that we have the state plans. I mean, because we have a federalism, so the states, they are supposedly independent and they needed to have their own plans. We also have tabletop exercise. There were two that they were well described and so on. And a full collaboration with international organizations that they are mentioned. That, of course, PAHO and WHO were right there, but we also have the Global Health Security Initiative. We have the Pandemic Influenza Preparedness in the North American framework, and so on. So we were working with those continuously. And there's more, because since long time ago, Mexico National Referral Laboratory was part of the network of influenza report to the WHO, and it was the National Influenza Centers also since long time ago. But it was with the information that we were getting from the very few areas in the central part of Mexico. And also we report to FluNet, and we are part of the Global Influenza Surveillance and Response System, and so on. But we really need to understand what was the situation of our epidemiological surveillance system in Mexico before the 2009 pandemic, and by the time that these public health crisis emerged. And I separated in this table and what we did have in that moment, and the limitations and problems to actually give an immediate response to the pandemic. And we did have a sentinel epidemiological surveillance system, CISBE-FLU, in 2009. And we have a growing network of laboratory diagnosis, but it was based in immunofluorescent because it was the recommendation that WHO PAHO had for most of the middle and low income countries. And the most important technology, like real-time PCR and started with sequencing, was very centralized. It was at INDRE, but the rest of the laboratories in the country, all the public health state laboratories, because we have a network with one state laboratory in each country, in each state. So what we had, it was immunofluorescent, and not all of them were doing even immunofluorescent. So we did also have an online report from state epidemiology departments, but that was not going down to the jurisdictional part or the most remote areas in Mexico. So all the information has to go to the capital of the state to be loaded in the system. I mentioned about the technology centralized and focalized at INDRE. And we didn't have a BCL3 or biosafety and biosecurity training officially. It was sort of developed at INDRE, but not everywhere. We only have one BCL3 laboratory, and it was in one of the public state laboratories in Veracruz. So one of the important things is the CISBE-FLU by that time did not include reports of influenza hospitalizations. They were all primary care units. So you can see the limitations that we have. One of the problems was the CISBE-FLU had a very low report adhesion. So the states, it was less than 20% of the total states of Mexico that they were reporting every week to the epidemiological surveillance. So it was limited, the information that we had. And also, I was mentioning that the jurisdiction with manual data collection, they didn't have no infrastructure, IT infrastructure to have a real-time report for this information. And the other thing was the limitation to link the surveillance with all the clinical areas. So it was like the clinical part was not really engaged. And the knowledge about influenza was limited. They didn't really recognize the syndromes and to think about influenza. So also in INDRE, the National Referral Laboratory, by the time they have limitations to analyze possible new virus. So we were doing everything we were receiving from PAHO and WHO, but we didn't have a protocol for unknown respiratory virus. So you can imagine that we need to be absolutely honest that we cannot give an immediate confirmation of this new virus and all the other things that that I didn't mention before. So these were the limitations that we have at that time. And that was for surveillance. So what happened with the other part of the problem? Medical care and intensive therapy organization. Before April 2009, staff was not trained to prompt recognition and medical approach of serious form influenza in young adults. We were always thinking about the older population. And also there was lacks of plans of hospital reorganization to receive excess cases of influenza. And the strategic reserve, we did have some, but we have 1.1 million antiviral treatments. We were sort of 120 million people in Mexico at that time. But it was in bulk. So we needed to reconstitute that, and it was not easy to do it. And intensive care units, they did have little response capacity for the epidemic, and there were insufficient supplies for ICU, so others than just the antivirals. After September 2009, the whole thing has changed because we have intensive care doctor, internists, and other specialized doctors that they know how to respond to this type of syndromes. Hospitals with reorganization plans update clinical guidelines for the management of severe cases of influenza or severe cases of respiratory disease, equipment and maintenance action in intensive care journeys. Not enough for COVID-19, like every other part of the world. So, but still we had some that we didn't have in 2009. And the strategic reserve, all the hospital units, they have strategic reserves, very small, not enough, but still they have some. Availability of antiviral in the states and also to the federal level. And then we do have seasonal vaccine, which is for target groups, risk groups, and we have available equipment and supplies to support ICUs. So that's part of the things that we have used to start with the response to COVID-19. So, but we can get some conclusions so far about the preparedness and response plan for the influenza pandemic in Mexico, if we can think about them like lessons learned. So we did have a preparedness and response plan for influenza pandemic, and it was used because one of the criticisms is that we didn't use the plan. We used the plan, but unfortunately, the plan was designed to shield us from an external threat. We never thought that we were going to have the emergency in place. So that was also a lack of flexible standardized operating procedures to adapt them to unexpected situation. So we were lacking real SOPs, the tailored SOPs to work with them. And also we have insufficient link between the clinical areas and the influenza surveillance systems. The laboratory plan was well developed. And I think it was the best because we can expand it very easily, even with the limitations. Unfortunately, it was centralized. We needed to decentralize immediately. And it did work, but it took some time to develop that. So that's one of the big lessons learned now for COVID-19. We need to decentralize the most we can, assuring quality of the system as most as we can. So the pandemic came first before consolidating the surveillance network, including laboratory and the multisectorial operational strategy of the National Preparedness and Response Plans. So it's the first conclusion. I can avoid to mention something that is very important. When did it start the circulation of the H1N1 pandemic virus in Mexico? I mean, you almost know about this swine farm in Veracruz and the first cases in Veracruz. After 6 months of the pandemic, we recover all the samples that we had collected in the network from the beginning of that year, January 09, up to the moment of the emergence of the pandemic. And we retested. I mean, forgetting about if they were positive or negative in fluorescent. So we retested with real-time PCR, the new test. And we can find that in our surveillance system, the first case was in San Luis Potosí, the index case for our system, of course, in those samples. And the onset of symptoms was February 24th. It was a very young girl in San Luis Potosí. But you can see that in the following 2 weeks, we had samples that they were positive for the new virus in Nuevo León, in Baja California, Chihuahua, Mexico City, Tlaxcala, and the south and southeast came after that. Veracruz, it was at the end of March. So this swine farm and the whole thing about Las Glorias, pero de Veracruz has nothing to do with the distribution and the transmission that we had. So the beginning of the pandemic in Mexico was in the north and the center part of Mexico with this information that we have. So one thing that I really want to address, which is important as a lesson learned, is what happened when we did this retrospective analysis. So in this graphic, what we have in these bars is the whole year, 2009. And you can see all those bars are the different types of virus that we identified in that year. So in the beginning of the pandemic that you can see in the left, so there are different type of virus. The purple bars are the new virus, okay? So you can see that we have all sorts of different types of virus circulating in the beginning of that year. So you can see H3B, we have more Bs than ever. But the first case, you can see it here, is the one in San Luis Potosí, okay? So we didn't see this was coming, so because we missed these cases, okay? And it's true that even with the perfect surveillance system, maybe you're not gonna see this very small amount of cases that they are emerging, talking about the first 3 weeks. But at least this in the epidemiological week 12, why we didn't see it? And you can imagine all the obstacles that I mentioned and the limitations that I mentioned before, they were having an impact to delay this identification. Because when we noticed the problem, it was here in the epidemiological week 14, 15, and 16. And it was not because the system warning us. It was because the clinicians, infectious disease clinicians, they were just calling the health authorities saying, there is something wrong. We are seeing so many cases of acute respiratory disease. Some of them are severe. We are even seeing death, and these are in young people. So this is a big lesson learned. So as soon as this was notified, everything was in place. It was investigation, it was epidemiological alerts. At the same time, we saw the report of the cases of in the United States with the new virus, and immediately we sent samples because we weren't able, we started to see samples, influenza virus, that we could not type. We sent the samples to the National Microbiology Laboratory of Canada and CDC Influenza Division in the United States. And in less than 48 hours, we had the notification that we had the new virus. And Mexico notified to the rest of the country and the rest of the world the same night. We have the identification of this new virus. And in fact, we already have an epidemiological alert, national, a week before, saying that we call them intensification and prolongation of the influenza season, because we didn't know that we have the new virus. But the actions were taken as soon as the problem was identified. But we cannot forget that we have this time that we were not able to identify the new virus. And that was the big lessons learned. What do we need to do to decrease, to shortage this time in order to trigger better strategies for response, anticipate mitigation and control measures, avoid further dissemination, reduce economic, social, political, and human costs, and so on. So let's see what we have now, and at the same time, the information about burden of disease. So this is one study that Hugo Lopez Gatell and I coordinated a year after the pandemic emerged in Mexico, and it was a seroprevalence study, national estimation that we have. It was a probabilistic study, and in these tables, you can see the estimation that we have projected to population based in this seroprevalence. At this moment, we have around, of the first 30 million vaccines that we purchased, it was around less than the half that they were already delivered to the population. So some of this seroprevalence could be because of the vaccine. But anyway, you can see that we have around 40 million Mexicans that we already have antibodies against H1N1 after 1 year and the 3 first wave of the pandemic. So many more Mexicans became infected with influenza that can be detected by any epidemiological surveillance system. And it was a large epidemic with a great extension that implied a heavy burden for the country and the institutions. So you can see here that in this survey, we also have a questionnaire, so we could separate with vaccinated and vaccinated people. And by that time, only 35% of the population received the vaccine. But of course, we were targeting risk group, not all the population. So if we can see some of the burden of disease that is important to see here in this study, you can see that, of course, as you must know, if we analyze the monthly pneumonia and influenza mortality rates by group of age, the most impact was in the group between 5 and 59 years old. It was mostly young adults. And finally, we had an excess mortality in young people of 80%. So when they said, no, this was not a problem, it was not a big impact, 80% excess mortality in young population, it's a lot. Also, this is a summary of economic loss caused by the pandemic of influenza in Mexico. I'm sorry, this is in Spanish, but I can say that the economical sector included education, health, different markets like commerce, agriculture, restaurant, tourism, transportation, including airlines and others. So you can see the increase in spendings, it was in health and education, mostly health and education, but the loss, it was in the other sectors, economy sectors, that it was very important. And at the end, it was a big cost for Mexico. And that was a huge impact for the economy for the following years that we have. So in conclusion, it was an epidemic with great cost for Mexico, 83 excess mortality in young adults, 3.3 times maternal mortality, and it was 0.4 of the GDP. In the beginning, it was analyzed that it was 0.7, but then it was adjusted. So Mexico received international recognition for its transparency, honesty, and timely behavior without hiding information. That's true. Even that internally, the whole response was criticized. And it's hard to understand the limitations that you had to respond to an event like this, even now for COVID. COVID-19. But these help a lot to improve different things in Mexico. Like the system, the surveillance system for influenza was trained specifically in quality analysis. Most than anything is the laboratory network. I was listening to Dr. Vicari, and it's true. It was a great improvement in the laboratory in Mexico by the time, and we're going to mention that. So, but what do we need now? And this is the message, start seeing. We need to increase the visibility of the influenza epidemiological surveillance system. We need to use the data because the data is not being used as much as we would like to be used for the decision maker for so many reasons. And we need the position of the health sector in the activities of health promotion, vaccination, quality medical care, among others. And this is very important. As I mentioned before, the laboratory surveillance strengthening infrastructure is great. That's definitely great. And this is what we had in 2009, an all national referral laboratory, very limited. And it was because of that, the concept, the plan for a new national referral laboratory and to improve the network of laboratories in Mexico was great. And that has helped a lot, even with the limitations that we have now for the COVID-19 response. So we have a beautiful new national referral laboratory, and we were able to start now with 44 national network of public health test laboratory and support laboratories to report to COVID-19, all of them doing molecular testing. And we didn't have that by 2009. And in the network, it's possible to do everything. I mean, now to analyze different viruses, we need characterize of the virus, sequencing, antiviral susceptibility testing, and so on. So it's a great improvement that we have. But what's happening with the information of the influenza surveillance system? So we are still working with the reorganized system flu, but if you see the system that you have in the United States or the one that we have in Canada and others, there are different models, as Eduardo presented yesterday, that you combine all the data to analyze, to reach those objectives that Dr. Vicari was mentioning before. The early warning, contain outbreaks, to measure the impact in society and so on. Unfortunately, our system is based on CISP-flu, which is ILI, severe acute respiratory infection, beautiful virological surveillance, and a syndromic system that is part of the unique surveillance, epidemiological surveillance system of Mexico that includes pneumonia and severe respiratory infection. It's a descriptive report that we are receiving every week. It's basically mostly on confirmed cases compared to epidemiological week of the previous year, and they are not indicator of magnitude, dispersion, and a specific impact in groups of geographic or severity, even though we have data of hospitalization and severe cases. So it's better. I'm not saying it's not better, it's much better, but still we need to use the information because we are not using the information in the right way. And this is an example of we have over the seasons, influenza seasons after pandemic, and we can easily see that it's a sentinel system. They are not 300 units, they are close to 700 units, and this is, there are hospitals and primary care units, but even with that, they're under registration, that you can easily see in this data, in both, in death and hospitalization and cases. We could see these alternate one year and the other to see H1N1. We are still so focused in H1N1. So, and we've been having very hard seasons with A3, of course. So there are other things that we need to analyze. We have information coming from all the states for at least to see the trend that we are looking in this, and a beautiful virological surveillance that we have in Mexico to see the moment after how the type of virus are changing over the season, the positivity, and this is used to estimate cases, both the combination of the laboratory surveillance with the syndromatic surveillance. But again, this is not, we could use more of this information because it is within situ. We could do it a much better analysis. The laboratory information is also giving us, for example, the lineage of B virus that they are circulating in the country, but we are not using to know what is the impact of this. If we have a mismatch or not mismatch, how is the impact in children, in severe cases, hospitalizations, and so on. The characterization with sequencing of all these virus, we can analyze if we have a match with the vaccine that we're using, that we're still using trivalent vaccine. And one thing that is very, very important that I want to show you is that even though the analysis and report has improved, we have incidence rate, there are other indicators now, we have this data that this interseasonal outbreaks that we are seeing, or transmission that we are seeing in the southeast of Mexico, in the Yucatan Peninsula, as I mentioned yesterday. Here is this, for example, in 2018, this it was H3 virus circulating with mortality increased, of course, hospitalization increased, ICU occupancy in Yucatan and in Quintana Roo, mostly in Yucatan. And you can see that others, it's like a continuous transmission. You are not able to see because they were not as big as this. And it was coming from the last 3 to 4 years seeing this. But this final summer, we didn't see anything, that even that we were looking directly. There are different hypotheses that it seems that tourism coming from the south, Brazil, Argentina, others, to the Caribbean resorts in Mexico, maybe they are bringing the seasonal the hemisphere seasonal influenza coming to Mexico. But the thing is, do we have by seasonal transmission of influenza in Mexico? What are we going to do with that regarding vaccination and other measures? So that's one thing, an agenda that we really need to address, that we haven't done that. In terms of burden of disease, there are very few slides. We have very few data. We can see that these manuscript presented influenza in the school-aged population in Mexico, burden of disease and cost effectiveness of vaccination. It's easily to see that in most of the seasons, the incidence of influenza is most in the younger population in this group of age. But if you see older groups of age, of course, depending of the virus circulating. If you're seeing H1N1, so you're going to see increased mortality and severity cases in younger groups of age. But if you are seeing H3, so you are seeing the extreme of the groups of age in this. Also, in this other manuscript also described that the estimated influenza-related events avoided by immunization in school aged population. And you can see that there are quite a big avoided population by vaccination. Vaccination coverage in children for influenza, it's very good in Mexico. However, even that the official data coming is that we have a total coverage of over 95%. We call them administrative coverage because, in fact, they are not respecting the real risk groups that they are focused for the influenza vaccination. But anyway, even with that, we can see this analysis that is presented that the influenza-related events, they are quite big. They're big, even for hospitalizations. And we need to understand that we have limitations in the general data. Sorry, this is not allowing me to. In terms of cost, there's this study also demonstrated that if we present different scenarios, like a very low conservative scenario versus a base case scenario or optimistic, depending of the vaccine efficacy and also the vaccination coverage, there is savings. I mean, in terms of a lot of money saving if we improve vaccination in Mexico. So this is an important data. Other groups are analyzed the comorbidities impact in the cases positive for influenza, and you can see that what we know, and it's known also in COVID-19, that the problem with the Mexican population with overweight, obesity, diabetes problem that we're seeing in younger age is having an impact in, definitely an impact in the outcome of these populations, even in pediatric population, which is important to address. So how we use all this information? This is in Spanish, sorry, but it was so crowded I couldn't translate all, is the algorithm of diagnostics and surveillance that we're using now. It was going from use the influenza surveillance system for COVID-19. And in the beginning, it was first influenza, and if it was negative, go for COVID. When COVID was increasing so much, it was the opposite. We are going first for COVID and then influenza, then all the labs. And not just the labs, it's the pre-analytic and post-analytic registration, loading the data in the surveillance system and so on. Everything was overwhelmed. So everybody was complaining and say, I cannot do all the 100% negative samples for COVID, for influenza, because there are a lot. So we're talking about many samples. So we reduced to go for 10% of the ambulatory cases to go for only 1% to look for influenza cases. And in the severe cases, yes, we needed to keep going with 100%. And this was first for the peninsula, because we were worried about the summer peaks. And doing this, we didn't find any case. And the other thing that I want to say is that even that we started for 44 laboratories, the National Referral Laboratory developed this system to do invitation for other laboratories to participate in the surveillance system for COVID. And now we have 190 laboratories reporting to the system. And hopefully we are going to keep going that, not just for COVID, but also for flu, which is really very good. So finally, what I want to say is that improving the analysis of influenza information and its dissemination would be a great benefit to adequately guide prevention and control actions at all levels of care. And even with the limitations, even with all the problems that we have in Mexico to respond to COVID-19, this has been a big help, a really great help to base in the influenza lessons learned. We must preserve what we have and maintain quality, as well as optimize its use in other priorities of public health. If we know how to respond to critical situations and learn from it with planning based on scientific evidence, we can serve better. So lessons learned in the 2009 influenza pandemic have helped to respond to COVID-19 no matter what. Thank you very much. If you have any question, I'm happy to answer.
All right. Well, thank you so much. That was a very interesting summary of Mexico's surveillance and response beginning in 2009. We actually have a few minutes for questions. I didn't see any pop in here in the chat section, or the chat here. Would anybody like to start us off with any questions? Yes, John Andrews.
Yeah, two comments. One is a common theme about the importance that David Morin's alluded to yesterday in his intervention, the importance of maintaining this capacity and using it to benefit not only flu, but the COVID understanding. And it's so critical, this network has been developed over the years. And the second is that I just to congratulate both speakers. They were outstanding presentations, and to acknowledge I'm so pleased that Celia in Mexico is also leading the COVID strategic planning if and when a vaccine becomes available for Mexico population, and it's she's doing an excellent job. I just wanted to say that.
Thank you, John.
So I just agree with John. Two terrific talks. Thanks so much. I want to bring up something that Dan Olson's been involved with, and we've been involved with in the center, and that's to look at influenza immunization programs with large businesses. And we know from yesterday's talk that there are significant savings in these large businesses when people are protected from influenza. And are there opportunities to partner with the private sector and these businesses in terms of demonstrating the value of immunizing their workers? And has that been on the radar of public policy decisions? Dan may wanna, because he's right in the midst of trying to show how important this might be, you might want to comment if I've not explained things or asked the question in the right way. Over.
Yeah, I'm happy to comment a little bit. I mean, I think one of the things we've seen in Guatemala is that we work with these large agribusinesses, so bananas, palm oil, sugarcane, and oftentimes they have thousands of workers who undergo annual serosurveys for exposures to pesticides, hepatitis, whatever the government wants. And so we saw that as potentially fulfilling two goals. One, to conduct serosurveys and look at seroconversion and disease prevalence, whether it's influenza or dengue or what have you. And the other part we've been interested in is using that as a mechanism to provide influenza vaccine, because there's probably an economic benefit. I don't know if it's cost savings to these large employers, but perhaps cost effective, at least from a public health standpoint. So we've been interested in partnering with these large agribusinesses, and that's part of an ongoing study we have right now. But I'm aware that Mexico also has many large similar businesses, and I think Steve's question is a good one, is what's the role of the private sector in helping to facilitate maybe a little bit surveillance, but also prevention and control strategies. Yes. Okay, well, Celia, go ahead, and then Dr. Ignacio Santos can go after her.
Well, the Mexican Institute of Social Security, which is covering health insurance for most of the employees, they are doing vaccination, but they are not focusing in the productivity. They are most focusing in risk groups similar to the rest of the Secretary of Health. So I don't have any information. Maybe Dr. Santos has more information about programs that they are related to different sectors of the economical part of the country. But it's a great idea. I would think that we can discuss that within the country and leave it with that. One of the problems that we face this year, and I wanted to point at, is the shortage in influenza vaccine, because so many countries, as never happened before, many countries that they were preparing for this a combination of flu plus COVID. We didn't have this information of the low transmission in the southern hemisphere. We were trying to get more vaccines than the usual purchase per year, and it was not possible because you really need to plan because of the production in advance. So I don't know, and maybe Dr. Santos has most information about the economical sector in Mexico.
Well, I think it's a very good question. The big difference is that in Mexico, the vaccine is free. So there's not a big incentive for private sector to purchase into the situation. As you probably do not know, but Mexico, the blue collar worker basically has a health insurance that is government run, that's Social Security system. The bureaucrats have a similar system. So all of those workers have a right, if they are within the age group that is being targeted, to vaccination. That being said, there's little incentive in the past for the various vaccine producers to introduce vaccines in a timely fashion in Mexico. For example, for the first year of this year, influenza vaccination started early. Yet, for the private sector, with very small volume, that's not going to happen until November. The vaccine will not be here until November. And as Celia pointed out, we're applying the trivalent vaccine. The quadrivalent vaccine is a non-entity right now. So I think that the public-private responsibility is definitely there. And I think that it behooves the government to do a little bit more to ensure a more global vaccination. As Celia pointed out, there's only a little more than 30 million doses being acquired this year. And that being said, it may not be enough given that we're so concerned about COVID. And but again, I think that the model here is predicated on free vaccine, where everybody is a government basically declaration that vaccination and all vaccines are free.
All right, thank you so much. I think we could probably take at least one more question if there's anything pending. Okay. So, Alba, did you have a comment or a question?
I raised my hand, so if I can make a question. Thank you. Thank you so much. Great presentation, Dr. Celia. I just was wondering, in terms of, I mean, based on what has been observed, that right now the circulation of influenza is lower, we'll need probably, considering the future influenza vaccination campaigns or influenza vaccination seasons, to make sure that we continue doing advocacy for the importance of influenza vaccination. So I just was wondering if you can speak, because it would be super great to learn from your experience, since you have great data, to see how you're planning to use this data to talk to decision makers and ensure that there is still commitment in the context of competing priorities and COVID vaccination and so on to continue vaccinating against flu. Thank you.
What a great question and responsibility for the NITAC that we are discussing, that we discussed it. John is in our NITAC, Dr. Santos is in our NITAC, Alba Maria is with us in every week discussion that we have for the COVID-19 vaccination and so on. So we had the discussion for influenza since before. So it was also discussed the need to improve vaccination because to plan the possibility of the combination of flu and COVID-19. And as I mentioned, we weren't able to expand the number of vaccine purchases because there was not enough in the market for that, okay? And I wish we can have more data to actually use them to keep doing advocacy to all the decision makers, how to improve and not to decrease the importance of influenza, because as Dr. Vicari has mentioned in the chat, this is unpredictable. It could be that it was low transmission in the Southern Hemisphere, but we don't know. I mean, that moment was happening with everybody was in containment, and now basically everybody's out. So we don't know what's going to happen with influenza. So we've been doing that with all we can do through the NITACs, the recommendations. They have been continuously discussed with that. We are using this information to try to make the best prioritization for the COVID-19 in the conditions of limited access conditions that we're going to have. And it's even worse because when we have this information that our countries are doing national, I would say, negotiation to buy vaccines in addition to the COVAX, we're seeing that if we are, there's hope that we're going to have a good vaccine. Maybe the most probability is we're not going to have one kind of vaccine. Maybe we are going to have 2 or 3 during the first year. They are going to be arriving step by step. I mean, it's going to be scaling the vaccination. So I need to be absolutely honest. This strategy is going to be a nightmare. We don't know how we're going to address this in the country. So maybe it's going to be a different efficacy. Maybe it's going to be a different storage. Maybe it's going to be, so we need to address that. It's not just to write down the papers and the beautiful publication about this. It's to think, how are we going to operate this in the field to actually deliver the vaccine, both, I mean, COVID, the influenza, or any other vaccine that we're having, with the impact that we're having to decrease vaccination cover for other vaccine preventable diseases. So it's a real challenge.
Then, if I can.
Yes, go ahead. Thank you, Ella Maria.
Thank you so much, and congratulations to both the speakers and Celia for that presentation. I would like to say that PAHO is also promoting the generation of evidence on economic burden of influenza, and there have been some workshops and countries are doing that. And that is important to transform that information, to translate that information to the policymakers in order to see and advocate for priority and for resources in order to maintain influenza surveillance and vaccination. And some countries are also adding or have added groups, high-risk groups, for example, farmers and teachers and other groups. That is evolving, and more countries are including these groups in the vaccination plans at national level. That's I want to share with that. And regarding the questions of vaccine effectiveness, I think that we are going to address that on Friday. Unless that you want me to answer something on that, we can do that on Friday.
Yeah, I think it's okay to say that one for Thursday or Friday.
Okay.
So yeah, no, thank you very much.
Thank you.
Okay, so I think we'll wrap up this morning's disease burden session. We will have our internal IAGE meeting right here. Similar to yesterday, as you should have received a Zoom link to the meeting for the committee members. And we will plan to reconvene tomorrow, same time, to discuss the response to seasonal influenza prevention and control, and kind of focusing a little bit more on the interface of influenza and SARS-CoV-2. Thank you so much, everybody. Olivia, if you can jot down some of these comments, or at least record them, that would be really helpful. And please reach out, anybody, if you have questions or any logistics issues. Thanks so much.